Welcome to the deep dive. This is where we take your source material, those notes, maybe articles you've been looking at, and we really uh, try to unpack them, pull out the core insights. The idea is to get you informed quickly and clearly.
Yeah, think of us as helping you cut through all the detail, zeroing in on the facts that, really matter and hopefully stick.
Exactly. And today, our focus is on something from your notes, gingival hyperplasia. Sounds a bit technical, maybe.
It can sound that way, yeah.
But it's basically a condition affecting gum tissue. Understanding it properly is, well, it's pretty important for anyone in health sciences, wouldn't you say?
Oh, definitely. It's something you'll likely come across either in studies or in practice. So getting a good handle on it is, yeah, really key.
Right. So our mission for this deep dive is simple. Walk through your notes on gingival hyperplasia. We'll cover what it is, what causes it, the etiology, how it looks, how it's managed. We want to make these details clear, easy to remember, ready for you to use, whether that's for revision or, out in the real world.
Let's treat it as a high-yield tour, focusing on the absolute essentials from your material. Sound good?
Sounds great. Let's dive in. First things first. What is gingival hyperplasia? Your notes define it pretty concisely as abnormal enlargement of gingival tissues. Can you expand on that a bit? What does that actually mean day-to-day for someone?
Sure. It's more than just temporary swelling like you might get from, say, minor irritation. The notes point out that in hyperplasia, the gum tissue itself actually thickens. And critically, this overgrowth can start to, well, grow over the teeth.
Ah, okay. So it's a physical increase in the tissue that changes the gum line.
Exactly. And that creates, as your note suggests, sort of a double problem. There are the aesthetic concerns, how it looks, which can be significant. But maybe even more important are the functional issues. If gums are covering the teeth, it makes things like cleaning properly really difficult. It can affect eating, sometimes even speech.
Okay, so abnormal, potentially problematic overgrowth. Got it. Now, the big question, why does this happen? What triggers this enlargement? Your notes list various factors under etiology, basically the causes. What are the key ones mentioned?
Yeah, the causes are quite varied, which is definitely something to remember. Your notes break them down pretty well. First, there's mention of a genetic predisposition. Sometimes it just runs in families.
So it can be hereditary?
That's right. The notes mention hereditary gingival fibromatosis specifically. But probably the most common cause you'll encounter, and one that's really crucial to remember for exams and practice, is medication-related.
Ah, drug side effects.
Yes, and your notes are specific here, which is helpful. They call out anticonvulsants like Phenytoin, immunosuppressants like Cyclosporine, and calcium channel blockers. These are common drugs, so this type of hyperplasia isn't rare.
Okay, Phenytoin, cyclosporine, calcium channel blockers, definitely need to remember those.
Right.
What else is on the list?
Hormonal changes are mentioned. Pregnancy is a classic example cited in the notes. The hormonal shifts can really affect how gum tissue responds.
Right.
Then there are local factors. Things like, poor oral hygiene, chronic inflammation right there in the mouth. These can contribute or make it worse.
That makes sense. Inflammation causing swelling.
Mm-hmm. And finally, systemic diseases are noted. Leukemia is highlighted. Your notes even specify the myelomonocytic and monocytic types. That level of detail is important. And hereditary gingival fibromatosis comes up again here too, viewed as a systemic condition affecting connective tissue generally.
Wow, okay, so genetic links, those key medications, hormones, local hygiene issues, and then serious systemic conditions like specific leukemias. Remembering that list feels really important for figuring out the root cause.
It absolutely is, because figuring out the why is the first step to figuring out the what to do about it. And yes, those specific drug names, the leukemia types, that's high-yield stuff.
Okay, building on the causes then, what makes someone more likely to get this? Your notes have a section on risk factors. I assume there's some overlap.
Yeah, significant overlap, which actually helps reinforce the key points. The notes mention family history again, that genetic link.
Makes sense.
And those medications pop up again: Phenytoin, Cyclosporine, calcium channel blockers. Seeing them listed as both causes and major risk factors really emphasizes their importance.
Right, it hammers home how often they're involved.
Exactly. Poor oral hygiene is listed again, too. Hormonal changes are reiterated. Puberty and pregnancy are mentioned specifically as periods of higher risk. And systemic diseases come back, repeating leukemia and adding Crohn's disease, which your notes flag here as a risk factor even if it wasn't explicitly under etiology.
So family history, being on those particular meds, maybe struggling with oral hygiene or going through hormonal shifts like pregnancy, all raise the risk. And that link to leukemia or Crohn's is a critical flag.
Definitely. Being aware of these risk factors is crucial for identifying people who might be susceptible or for helping narrow down the cause when you see it.
Let's get a bit more technical for a moment. How does this actually happen at the cellular level, the pathophysiology? What are the notes saying about the mechanism?
Right. The notes explain it varies a bit depending on the cause, but the core process generally involves two main things happening in the gum tissue. There's an overgrowth hyperplasia of the gingival epithelium, that's the outer surface layer, and importantly, there's also an increase in the number of cells hyperplasia again, and sometimes the size of cells hypertrophy within the gingival connective tissue. That's the bulkier layer underneath.
So it's affecting both the surface layer and the underlying structure. Both are growing.
Yes, exactly. It's not just one thing. The notes add a bit more detail, mentioning mechanisms like chronic inflammation triggering cells to multiply, or maybe abnormal cell signaling pathways being activated, or even an imbalance in tissue remodeling, where the normal breakdown and buildup gets out of whack, leading to more tissue overall.
Huh. It's quite complex behind the scenes then. Now, if someone comes in with enlarged gums, could it be something else? What's on the differential diagnosis list in your notes? Sounds vital not to just assume it's hyperplasia.
Absolutely vital. The differential list helps guide your thinking. Your notes list several key things to consider. Simple gingivitis, just inflammation, usually not that massive overgrowth. Periodontitis, more severe gum disease affecting bone, often involves recession, but inflammation is there.
Okay.
Interestingly, your notes list drug-induced gingival enlargement separately again here. Even though it's a type of hyperplasia, its commonality means it gets its own mention.
Highlighting its importance.
Exactly. Hereditary gingival fibromatosis is on the list too, reminding you it's a distinct genetic entity. And crucially, certain oral cancers. That's a big one. It really underscores why sometimes further investigation, like a biopsy, is absolutely necessary if things don't look typical or the cause isn't obvious.
Okay, so differentiating from simple inflammation, more severe gum disease, specifically drug-induced forms, genetic types, and even ruling out cancer. That really drives home the importance of a proper workup.
Mm-hmm. Correct diagnosis leads to correct management. That's the goal.
How common is gingival hyperplasia? What do your notes say about epidemiology, especially thinking about the UK?
Yeah, the notes are pretty straightforward here. They say the exact prevalence in the UK isn't well documented. Hard numbers are scarce. However, it is considered relatively common overall.
Relatively common.
Feels a bit vague, though. What makes it common if we don't have solid numbers?
The notes give the context. Its frequency is really tied to how often those key medications we keep mentioning, phenytoin, cyclosporine, calcium channel blockers are prescribed.
Right.
Since those drugs are used pretty widely for epilepsy, organ transplants, blood pressure,
Yeah.
the side effect, the drug-induced hyperplasia, is seen fairly often as a result.
Okay. So its commonness isn't random. It's directly linked to the prevalence of its main causes, especially those drugs. That makes more sense. Exactly. It's a side effect you'll encounter if you work with patients taking these common medications.
Let's talk about what it actually looks like, the clinical presentation. What does it look and feel like for the patient? What are the key signs and symptoms listed?
Well, the most obvious sign, as the notes describe, is that visible overgrowth of the gum tissue. The gums look swollen, enlarged. Sometimes it can be quite dramatic, actually covering parts of the teeth.
So the gum line seems to creep down the tooth.
Yeah, that's a good way to put it. The notes also use descriptive words for the appearance, like the gum margins might look bulbous or blunted.
Bulbous or blunted,
Yeah.
okay. And what about the texture? Is it soft, inflamed?
It can be, but your notes specify it can also feel quite firm and fibrous to the touch, not just puffy. The color can vary too. Sometimes it looks pale, which fits with that fibrous texture. Other times it might be quite red, erythematous, especially if there's secondary inflammation happening because, cleaning is harder.
So, enlarged, maybe covering teeth, looking bulbous or blunted, feeling firm and fibrous, and color could be pale or red. What about how it affects the person day to day?
Yeah, the notes highlight a really important functional consequence. The overgrowth makes it physically difficult to clean the teeth properly around the gum line.
Right.
And that difficulty cleaning often leads to secondary problems like bleeding gums, sensitivity. It can become a bit of a vicious cycle.
Difficulty cleaning leading to bleeding and sensitivity. Yeah, that seems like a major issue. Recognizing those visual signs and the functional impact sounds key.
Absolutely. Being able to describe the appearance and link it to the patient's symptoms is fundamental.
So how do clinicians nail down the diagnosis and figure out the cause? What investigations are typically used according to your notes?
The notes emphasize starting with a thorough clinical examination, actually looking closely in the mouth, feeling the texture of the gums.
The basic hands-on assessment.
Right, that's the foundation. But, and this is crucial, it needs to be combined with a really detailed medical history. That's vital for checking that medication list we keep talking about and also for understanding their general health. Are there any clues pointing towards leukemia or Crohn's, for example?
So exam and history are the cornerstones. Are other tests usually needed?
Sometimes, yes. A biopsy might be necessary. The notes suggest this, especially if the picture isn't clear, the cause isn't obvious, or, importantly, to rule out other things on that differential list, particularly malignancy.
Okay.
Dental radiographs or X-rays are also mentioned as being useful. They can help with diagnosis and are especially important for planning treatment, particularly if surgery to remove tissue is being considered.
So the investigations are really about confirming it is hyperplasia, pinning down the specific cause, and understanding the extent of the problem to guide what happens next.
Exactly. You need the full picture before you decide on the best way forward.
Okay, so once you have the diagnosis and understand the cause, how is it managed? What approaches do your notes outline?
The absolute key principle highlighted in the notes is that management is cause-dependent. You have to tackle the underlying reason. Just removing the overgrown tissue without addressing why it grew in the first place often means it'll just come back.
Go after the root cause. Makes sense.
Precisely. So the notes list several approaches. The foundation is always improving oral hygiene, better brushing, flossing, and having regular professional dental cleanings to get rid of plaque and calculus, those local irritants.
The basics of good oral care.
Essential. Then, if a medication is the culprit, the notes mention medication adjustment. But, and this is a huge caveat, this must be done under strict medical supervision by the prescribing doctor.
Right, you can't just tell someone to stop their epilepsy meds.
Absolutely not. It's a careful balancing act. The doctor has to weigh the severity of the hyperplasia against the need for that specific medication. Sometimes switching to a different drug in the same class might help, but it's a complex medical decision.
That point about medical supervision is critical. What if the overgrowth is really severe, though? Interfering with chewing or making cleaning impossible?
In those cases, or if it persists despite other measures, surgical procedures are listed as an option. This usually means a gingivectomy or gingivoplasty, basically, surgically removing the excess gum tissue to reshape the gums.
So surgery to physically reduce the bulk.
Correct. And finally, the notes stress the importance of regular follow-up appointments. These are needed to monitor how things are going, check for any recurrence, and provide ongoing maintenance, especially if the underlying cause can't be completely eliminated.
So it's a multi-pronged approach. Hygiene first, address irritants, consider medication changes carefully with the doctor, potentially surgery for severe cases, and then ongoing monitoring. Very patient-specific.
It really is, and often requires good communication between the dental team and the medical team, particularly when drugs or systemic conditions are involved.
What's the typical outlook for someone with this condition? The prognosis section in your notes, what does it say?
Well, the notes indicate that the prognosis is quite variable. It really hinges on the specific cause, how well that cause can be managed or eliminated, and, individual patient factors.
So can it usually be cured or reversed completely?
In many cases, yes. Proper management, especially if the underlying cause can be successfully addressed, like switching a medication if possible and appropriate, often leads to really effective control and significant improvement in the gum tissue. However, the notes do add a note of caution. Complete resolution might not always be possible. They give hereditary gingival fibromatosis as an example. That's a lifelong genetic thing, so the tendency for overgrowth might persist and require ongoing management or repeated treatments.
Ah, okay. So while improvement and control are common, a complete cure isn't always guaranteed, especially with genetic causes or if someone has to stay on a causative medication.
Exactly. For some individuals, it becomes more of a chronic condition that needs long-term management rather than a one-off fix.
And lastly, what happens if it's not managed well or just left untreated? What are the potential complications listed in your notes?
The notes basically group complications into two main areas. First, there are the functional issues. As we've said, the enlarged gums make good oral hygiene really difficult, creating that cycle of inflammation, bleeding, maybe even leading to more serious gum disease over time. Severe overgrowth can also physically interfere with speech and chewing properly.
So practical problems with using your mouth.
Yes. And the second area is aesthetic concerns. The notes mention that the appearance of significantly overgrown gums can understandably cause psychological distress and really impact someone's self-esteem and confidence.
Yeah, that makes total sense. Our smiles are very visible.
hmm So the notes really emphasize that intervening early and managing it properly is key to preventing these functional and aesthetic problems from becoming major or long-lasting issues.
Right. So putting this all together, we've seen gingival hyperplasia is definitely more complex than just swollen gums. It's got this wide range of causes, genetics, local stuff, those key medications, even serious diseases like leukemia. It presents differently, and management absolutely has to target the specific cause.
Yeah, and if you take a step back, think about the bigger picture. Gingival hyperplasia is actually a really good example of how interconnected our bodies are.
Interconnected. In what way?
Well, think about it. Here's a condition manifesting in the mouth, but so often it's a direct result of something happening elsewhere. A medication someone needs for their heart, or epilepsy, or an organ transplant, or a systemic disease like leukemia or Crohn's. Managing it effectively often means looking beyond the mouth, considering the whole patient, their full medical history, their overall health. It really drives home that oral health isn't separate. It's deeply linked to systemic well-being.
That's a really powerful takeaway. It's not just a dental issue. It can be a systemic sign, a flag. And that brings us to the end of our deep dive into gingival hyperplasia, based on your notes. We've covered the definition, the really crucial causes and risk factors, remember those key drugs, how it happens pathologically, how to spot it clinically, the investigations, the cause-focused management, and the potential outcomes and complications.
Hopefully, breaking it down piece by piece like this, highlighting those high-yield points, makes the information feel a bit more organized and easier to recall for your revision.
Absolutely. Nailing these details, especially the specifics your notes emphasize, is so important for building confidence, whether for exams or for clinical practice.
And, if you're finding these kinds of deep dives helpful for revision, particularly for exams like the MSRA, there are more resources available.
Definitely. You might want to check out pastmsra.com and also freemsra.com. Lots of helpful content there designed to get you prepared.
We really hope this exploration has been useful, helped clarify things, and leaves you feeling well-informed and ready for whatever's next.